Good afternoon. Welcome to this briefing on a very important landmark study produced by the Dobson and DaVanzo organization that will reveal substantial differences between what happens to patients if their initial rehabilitation is received in a rehabilitation hospital in contrast to a nursing facility. I'm Dr. Bruce Gans. I'm the chair of the board of the American Medical Rehab Providers Association, which through its subsidiary, the ARA Research Institute, commissioned this study. I'd like to express my deep appreciation to Senators Kirk and Johnson and their staff for supporting the ability that we have to present this information to you today, and to all the care and support they've given us over the years for the field of medical rehabilitation and hospital care, because they have a personal experience with it and know what unique value it is. On today's presentation, in addition to myself, you're going to be hearing from Dr. Al Dobson, who is the president of the Dobson DaVanzo Associates and the lead investigator on this study. You're also going to be hearing from Dr. Terry Sheehan, the medical director for the Amputee Coalition of America, and Susan Connors, who is the president and CEO of the Brain Injury Association of America. We're also very pleased to have as additional sponsors helping us to explain the results and the meaningfulness to the Amputee Coalition of America and the Brain Injury Association of America, and also the Coalition to Preserve Rehabilitation. All of these organizations represent consumers, and I think one of the takeaway messages we would really like you all to appreciate from this study is that this is not a study about doing good for the businesses and the rehabilitation providers and physicians and therapists. This is about the right things to do for patients, for people who need our care, and the benefits to be received in a variety of settings, but the unique service benefits that are derived from rehabilitation hospitals. And we hope that the evidence will help to explain those findings far better than I could in this period of time. I want to also express my appreciation to the Senate Banking and Finance Committee staff for making this room available to us, and hope that you will respect the room and keep it clean and orderly. And please, at the end of this session, when you're ready to throw away your trash, there's a big bin there. I'm delighted to observe that Senator Kirk has joined us. Okay, Senator Johnson, and we'd be happy to invite him to the podium if you would like to do so.
Thank you all for coming out today. Thank you also to the organizers of today's event for coordinating this important discussion about the value of complex rehabilitation, a topic that is very personal to me. Having experienced the benefits of intensive rehabilitative care firsthand, I recognize the important role that the rehabilitation plays in helping patients recover from physical or neurological trauma. Following a brain bleed in 2006, I was able to minimize the resulting functional disability through extensive rehabilitation and return to independence. Every patient's path to rehabilitation is different. Critical to achieving the best outcomes for each patient is to ensure that patients are provided the right care in the appropriate setting. I hope today's panel discussion provides some further insight into the differences in care delivered in alternate settings, and will help to inform the future rehabilitation policy debates. As the nation's health care system moves toward improving health outcomes and ensuring a better quality of life, it is important to recognize the value of complex rehabilitation and serving and achieving these goals. I worked closely with my colleague and co-host of this briefing, Senator Mark Kirk, to ensure access to this essential service for all Americans. I will continue working to improve rehabilitation care. Thank you for coming today. I hope you find the briefing informative.
Thank you very much, Senator. We appreciate your presence very much. It's very important to us. Very pleased that Senator Kirk is able to join us at this time.
I've called you all here because one of you is the murderer. I just want to share with you a vision that I have of federal policy on rehab. That, as you know, that 75% of stroke victims will not return to work. I think that's way too low. That we should get that number up. We should have more people with the chances that I and my colleague in the Senate, Tim Johnson, had to get back to work. I think we ought to set a national back-to-work regimen to make sure that we have peer-reviewed, scientifically valid ways to bring people back, make sure they get back in the workforce.
Right on.
Yeah, thank you. I'll complete the pitch saying that my colleagues should support it. If you, as you know, with patients who get back in the workforce, they will have higher wages, higher health status, better mental health. I think you can say that it pays for itself if you get them back into the workforce. And if we say, hey, all this stuff really works, and just do exactly what your physical therapist says, just treat what they say as the revealed word of God. It's gonna work, yeah. See a lot of friends in here. Guys, that's all I had to say. Thank you, everybody.
The main event is to hear the results of the study that Dobson and Devanzo Associates have presented. And I want to just take about 5 seconds to provide you a sense of context. There are multiple different settings in which rehabilitation services can be provided, and good things happen in all of them, but they're not necessarily the same, and they're not necessarily the same services that any individual patient can easily be substituted in one setting for the other. As a trade association representing rehabilitation hospitals and a variety of settings of care that rehabilitation provides, we felt that it was critically important to really have information and evidence to understand what really happens to people when they receive rehabilitation in various settings and what the true long-term consequences are of those initial setting decisions. Because as clinicians and providers, we know it's not all the same. We know good things can happen in either setting, but it's just not the same. And so we sent out an RFP asking a variety of high-level research organizations how they would approach answering this question. And we asked the Dobson Devanzo firm to take on the task of doing a best objective evidence evaluation and review of looking at a long-term review of what happens to patients if they're cared for in specific settings, to try to help us understand what is good clinically, what is good from public policy perspective, what is good from an advocacy perspective. And in order to do that, we work closely with the organization, Dobson Devanzo, but we said to them, this is your study. It has to be right. It has to be honest and objective. It has to be transparent. And we will live with the consequences of the findings. We want to make them known to people so that it can inform policymaking and clinical decision-making. So I'm pleased to introduce to you the president of Dobson Devanzo, Al Dobson, who is widely known in Washington. He's worked for more than 18 years at the Lewin Group before branching out on his own. Extraordinary individual. I've had a chance to work with him in previous studies, and wonderful to fight with about information and knowledge, and a great advocate for doing things the right way. And I think you'll all really appreciate and enjoy hearing the results of the study from the guy who took the lead on making it happen. So Dr. Al Dobson.
Thank you, Dr. Gans. We're very pleased to be here. My colleagues, Audrey Elgaville, Dr. Joan Devanzo, and Justin. We've spent some number of months on this, and before I start, I'd like to say that we're very excited about this for lots of reasons. We hear every day in the paper the stuff about big data this, big data that. And what's really interesting is if you use big data appropriately, it's very powerful. And we think we've been able to apply big data in a very powerful way in this particular study. The question we ask is a very difficult question. Are the results different if people go to different settings? In order to do that, you have to take the data and follow people across time. We followed people across 2 years. The computers now have enough power. We have enough statistical acumen now to do it. And stuff that 5 years ago you might not have been able to do at all, we were able to do now. Not easily, but we were able to do it. And we think this is the first time a study like this, for at least for this particular comparisons between the rehabilitation and SNFs has ever been done and produced. So we're very pleased to be here today to show you what we've done and how we did it. So we'll start out. The study highlights, as we've heard, the study was commissioned by the ARA Research Institute and AMRPA. And we're going to take a look at, we believe, the most comprehensive national study to date on this very important issue. Over a 2-year period, to get right to the findings, IRF patients, clinically and demographically similar to SNF patients, that is to say they were matched, I'll speak more of that later, returned home from their initial stay 2 weeks earlier, because their stay in the hospital was 2 weeks shorter than it would have been if they'd gone to a SNF, remained home nearly 2 months longer, stayed alive nearly 2 months longer, experienced an 8 percentage point lower mortality rate during the 2-year study period. As we'll see, that varied by a diagnostic category rather markedly, depending upon which category you're in. Experienced 5% fewer emergency room visits per year, and for 5 of 13 conditions experienced substantially significant readmissions per year. All of this was achieved at a slightly higher cost. It was $12.59 per day. Some things cost more, but if you get better results, it might be worth it. The value may be there. So what were we up to? We were commissioned to do this study. And one of the reasons we were selected is we had this large database about. It had 5 years of data in it. It had a 20% sample of skilled nursing facility SNF folks, and it had a 100% sample of IRFs. It was a custom draw from the Medicare program that we had drawn some years earlier, and it was a perfect database for this study because it had all the IRF patients in the country for 5 years from the Medicare program, and it had 20% of the SNF patients. Since there's so many more SNF patients, 20% sample was more than enough. We wanted to understand what happened to people as they left the so-called 60% rule, which say IRFs had to have 60% of their patients in 13 categories. And there was a real question, when the government put that rule in place, what happened to people? When they left the IRFs and they went to the SNFs, what happened to these folks? Did they have better results, the same results, and different results, or what? Was it good public policy to take people on an apparent attempt to save dollars and move them from one setting to another? And that was at the heart of our study. Was it good public policy to take people and put in a situation where the incentives were very strong to move people from one setting, from the IRFs, to another setting, the SNFs? So the objective then was to identify patient groups that have been affected by the Medicare payment policy changes that shifted patients from IRFs to other post-acute care settings, primarily from IRFs to SNFs. We wanted to look at the long-term effects, and as I've mentioned, the power of these large data sets is you can track people over time, in this case 2 years. So we had 2 years of patients. We spent an enormous amount of time working with Bruce's people, Dr. Ganz's people, and we really paid attention, Dr. DeVonzo in particular, what on earth were the clinical diagnoses we were looking at? How could we categorize people that they would be comparable? And we wanted to make absolutely certain that when we did this study, to the best degree possibly, we could have comparable people in both settings matched up. So when we gave you the results and said, we see less mortality, we see longer days in the community, that it's comparable people matched. We used a technique called the propensity score, and the propensity score is an attempt to, as it were, use these powerful data to give you results that are comparable to if you would have had a clinical trial. Obviously, they're not the same. We didn't have a clinical trial, but imagine, there are some things you cannot do a clinical trial for. This is one of them. You cannot randomly assign this bunch of people to this setting and that bunch. It just can't happen. Medicare has what's called freedom of choice. You all know that if you understand the program. On the other hand, to use the data and to give something that approximate a randomized clinical trial is very powerful, and we believe we've been able to do it. The literature suggests that the results that we have found are clinically and statistically valid. So here we go. The study context, under the IRF Prospective Payment System, IRF PPS, at least 60% of a facility's admissions must be in one or more of 13 clinical conditions certified by CMS, quote-unquote 60% rule. Medicare beneficiaries with certain conditions previously treated at IRFs are now treated in SNFs or other settings. The long-term effect on beneficiaries' health outcomes and healthcare utilization of being treated in other settings has not been studied to date. This study serves as the most comprehensive study to date for the reasons I've suggested. We had 100,000 matched pairs. I'll repeat that, 100,000 matched pairs. We have statistical power in excess in this study. How do we do that? We built what we call patient pathways. On the left side, and you have this in your handout, some of you I can see have it, so you can see the actual. We start with a short-term acute care hospital stay. Then somebody went, this patient either went into an IRF or a SNF. We picked them up as they enter the IRF or the SNF, and we had a post-rehabilitation period, which was 24 months. So we followed people for 24 months to get an understanding of what happened to them after they left the IRF, after they left the SNF, as they came out of the hospital before. We call that the patient pathway. Again, the power of these data is we can take each individual in the database, we can track them through 2 years after they left the SNF or IRF. We can match them up at people that went to SNFs and IRFs so they're clinically comparable. And then when we give the results, we're comparing likes to likes. A very powerful research design. So then after we did that, we matched on demographically, we matched on age, gender, comorbidities, prior healthcare utilization. So similar patients treated in IRF for the same condition based on the MSDRG and the IC-9s that led to the MSDRG following the hospital discharge. Clinical and payment outcomes are captured after discharge from the SNF, again for a 2-year period. So if you just kind of look at the picture, you can kind of get the idea. Come out of the hospital, go into the IRF or SNF, get your care, go out, follow up for 2 years. And that allows you to get the sequela to the care provided in alternative settings. Now, on the next slide, we show essentially that, yep, indeed, as people came out in 2004 from the 60% rule, the utilization, particularly the dotted line that falls from way high at 25% and goes down to 10%, that's hip and knee replacement. And some of the other, we have hip fracture and stroke. Stroke fell less, perhaps, and the hip and knee, which is the one in the middle, fell a bit. You'll see that as we move from the left to the right, there's a kind of a dotted line and a jog there. That's because we splined our data that we had in our database with some data from MedPAC, and our data didn't match exactly, but you can see that the trends, when we show downward trends, so did MedPAC. When we show it's reasonably flat with stroke, so did MedPAC. So the long and short of it is, after you move out of our study period of 2009, 2010, 11, and 12, we found a comparable kind of decline. That is to say, the 60% was very powerful. It did what it was supposed to in a certain sense. It moved people from the IRFs into the SNFs. But the real question is, what happened to those folks when that happened clinically? Now, as we look at the results, the first thing we find is that IRF patients left the rehab earlier and stayed home longer than SNF patients. Those of you that can see this fine print will note that the overall average reduction for length of stay was 13.9 days on the left, and then on the right set of numbers, days at home increased by 51.5%. We have 13 conditions here, which we spent a couple months building, actually. This was not an easy task. We put the data together, and we went over and over and over to get our people clinically identified. These are not, while there happen to be 13 conditions here, these aren't the same uniformly as the 13 conditions in the 60% rule. We wanted to get those conditions that made sense to us and the physicians that advised us, Dr. Gans and his colleagues, that would be the right conditions to really understand as best we could by clinically matching people within these categories what happened to them as they left the SNF and the IRF setting. So on this page, we see that we pick up the initial stays, your rehabilitation care in the IRF is 2 weeks shorter, and it's very intense. And as I'll say later, it's intense because of regulation. The regulation calls for physician involvement, physiatrists, physicians, very much more regulated than in the SNF setting. So you have a more intense, a high blast, as it were, of rehabilitative care in the IRF setting. It costs more, but it's very intense and apparently very effective. In terms of days at home, there's 51.5 more days at home. By days at home, we mean the patient is in the home as opposed to in a facility setting. From anybody who's ever been in facilities, you know you'd rather be at home than in a facility. So picking up 2 months is no small thing for a patient in 2 months and 2-year interval. On this slide, we show that patients had an 8% lower mortality rate during the 2-year study period than SNFs. And the important thing about this is, if you have it in your slides, you can see the detail, but you can see just looking at the longer bars show that people had a higher spread. That is to say, the spread between the IRFs and the SNFs was greater. So if you look at brain injury, the second line down, and you can see that long chart up there. You can't see the numbers, but that's brain injury. 16% less mortality in the IRFs than the SNFs for brain injury, and on it goes. Amputation had a large spread. Brain injury had a large spread. Cardiac disorders had a large spread. Pain symptoms had a large spread, and stroke, as you might guess, had a large spread. That is to say, with these kinds of diagnoses, the mortality rates were quite marked, statistically significant across patients in 2 years that were very carefully matched within diagnostic category. A very strong finding for this study. IRF patients stayed alive nearly 2 months longer than SNF patients. Not only did they die less, they stayed longer. The same kind of spread where you can see that some of the bars are quite lengthy, meaning that folks stayed along average additional days of life when receiving IRF care, matched IRF and SNF patients. 78 days for amputation, brain injury 93 days, stroke 97 days. That's picking up the number of days alive for patients carefully matched between IRF and SNF. Again, there's a lot of variance there, but the overall average is 53 days, and for the ones I mentioned, it's quite long indeed. IRF patients experience 5% fewer ER visits and significantly fewer hospital readmissions per year than SNF patients. A lot of pressure on ER. All across the country, we're seeing the ER overcrowded and attempts to keep people out of the ER as best we can if unnecessary. This study suggests that those patients that go to IRFs are 5% less likely to have an ER visit than those that went to SNFs. And on the readmissions is a mix. This isn't a clear finding as the others. We had 5 out of, I think, the 13 that were statistically significantly different in readmissions. We've looked at these data a lot for many different settings, and what we find is readmissions are just like the Medicare program says. They're rather problematic. You start home health, you start in an IRF, you start in a SNF, you start in a long-term care hospital. 60 days later, you all have about 25% readmission rate. Folks all over the country are going to work hard on that. Everybody has to work on that, including the IRFs, and that's what this study says. Very consistent with our other studies that we've done for other clients. Now, at the end of the day, it did cost a bit more. And what we show here is that IRF care resulted in better outcomes for an additional $12.59 per day. So we had wondered, and one of the questions we had, and the reasons we looked for 2 years is, if you followed the patients across 2 years, we were hoping that, or at least the client was hoping that, Dobson DeVonzo had no stake in the outcomes per se. But the wonder was, if you followed for 2 years, after maybe there'd be a cross and it would actually be cheaper because of the sequela of care. By that I mean, you come out of the IRF, you go, you have fewer readmissions, which we didn't see exactly. You have less care generally. Might it be cheaper across 2 years? It was not. It was slightly higher, slightly more expensive. But on the other hand, we found all the outcomes. Now, I want to put a very important caveat before I go to the next slides, and that is to say we matched IRF patients to SNF patients. This isn't to say all SNF patients would have the kinds of outcomes relative to the IRF patients we found in this study. Those that we matched, the 100,000 that we matched, that's what we found. There could be all the SNF patients that we didn't match to. We don't know what happened to those patients. So for those that we matched, the 100,000 that we matched, we're very confident that our results are solid, they're statistically reliable, they're statistically valid, they're exactly what we say they are. But there may be SNF patients that we didn't match that maybe don't go to IRF so much, or we just don't know. So all we can say for sure is those that we carefully matched to in the 13 conditions we looked at, the results I presented today are both statistically valid and statistically reliable. For those we didn't match, we just don't know. That's for another day. And that is a problem with these kinds of matching. You don't match everybody to everybody, but you match up as carefully as you can. And for those guys you can match, these are the results. These are the results I presented today. Now, in further considerations, Medicare fee-for-service claims do not include utilization for other payers. Obviously, Medicare claims don't include Medicaid. Many of you that don't know that Medicare statistical system, we don't have managed care in there either. So what we have here is a situation where 25% of the population, which is in Medicare Advantage, we don't know, this study cannot relate to them. But still, we have 75% of the fee-for-service. The bulk, the large majority of Medicare patients were in our sample, appropriately accounted for, and the results are generalizable to those folks. What we can't say, though, and this is really critical, when you're looking at older people that are in rehabilitation, they come out of a SNF, they may have come out of a nursing home. They may have come out of a nursing home for Medicaid. We may have thought that they were in the community, but they really weren't. They may have been in a nursing home. So we may have underestimated the spread between community care, being in the community between the SNFs and the IRF, because maybe many of the SNF folks came from a nursing home and went back to a nursing home. We just can't tell that. So I think I should just leave it. We can't tell, so we don't know. But it is a problem with the study. And it would have been nice to know more about managed care, but managed care doesn't provide information back to the Medicare program, so there's no way you can track those patients. One thing that we didn't have in our database, it was the way we built the data many years ago. We didn't have durable medical equipment, and we didn't have physician services. Imagine trying to get physician services, of which there are literally billions of claims into these databases. Very difficult, so we didn't even attempt it those years ago. That said, if we would have had DME, we might have found that who knows what we would have found. We might have found something different with the DME if we would have been able to track it. We didn't have it in the database. I can't speak to it. So in the study conclusions then, IRFs are known to provide intensive, standardized, and focused inpatient hospital rehabilitation under the direction of rehabilitation physicians. I've worked with Dr. Gans some years and years and years. I know a lot about how the IRFs work. They are different. They're wonderful places. You go there, they're upbeat. Imagine going into a place where people are quadriplegic and seeing an upbeat place. They're just amazing places. They're wonderful places to go to because what they do is very powerful, and that's what these results show. Not to speak as an advocate, but speak as an observer, being in a rehabilitation can be a very positive thing because good things happen relative to what might have happened if you don't go there. So the intense, standardized, focused inpatient hospital rehabilitation is very powerful. The data suggests that it does make a difference. And I was told a long time ago as I did a tour through a IRF, if you have a stroke, get stabilized and get these to a rehabilitation as fast as you possibly can, and it makes a huge difference, fast, quick, and hard, and that's what rehabilitation in these centers does for you. So what we've looked at then is this study focused on shifting patients out of an IRF immediately following the implementation of the 60% rule. We followed these folks for 5 years. MedPAC analyses has confirmed the trends that there was a shift as people followed the 60% rule, moved people out of the IRFs into the SNFs. As public policy, from a money point of view, maybe it was okay. From a patient point of view, which was, as Bruce said and Dr. Gans said, this study is all about, maybe it wasn't such a good piece of work because what it did is it exposed people to some risk, higher mortality, fewer days in the community, more emergency rooms, and on it goes with the variables we were able to look at. So the shifting of clinically similar patients out of IRFs into SNFs might have adversely affected Medicare beneficiaries. Again, and I've said this many times, but it's just so important, we matched our patients treated in the SNFs instead of IRFs, and they had an increased risk of death. More facility-based hospital care. That would be care in the hospitals, or SNFs and LTACs. And they had more ER visits, and they had more, about the same, and to some slightly less hospital readmissions. So that said, the study variables we looked at were positively and favorably inclined to show that if you go to an IRF, you have better outcomes than if you go to a SNF. For those that we were able to match, as I said. We felt that was a very powerful finding, and it did confirm everything we were looking for except for the cost thing, which was slightly higher. And again, costs a little more, but it seems to provide value. Thank you.
We are going to have time for questions and answers after we hear from 2 other speakers. And I'm going to now introduce to you Dr. Terry Sheehan, who is the Chief Medical Officer for Adventist Rehabilitation Hospital and the Medical Director for the Amputee Coalition of America. And he's going to speak to the specific perspective of patients with limb loss.
Good morning and thank you. It's my pleasure to be here. And for the world that I represent, this is an amazing study about the people that I treat and advocate for every day. I am a physiatrist, a chief medical officer for an acute rehab hospital, and I also work in the skilled nursing, the other side of the study environment as well. So I'm very clear on who is in which setting. And every day I need to take calls from a team of nurse liaisons to help them decide who should come to which setting. So I live and breathe this every day. I am also the medical director for the Amputee Coalition of America. This is the only advocacy group for those with limb loss in America. And I know that we've seen the face of the amputee through the tragedy in Boston, through our conflicts and our soldiers and military personnel who have lost limb. The numbers are so much more dramatic in America every day. We see up to 500 people losing their limb every day in America, and that's because of diabetes and obesity. That's a dramatic number, and they're kind of this hidden group that in our healthcare system, they end up at risk because of the fragmentation. So in every acute care hospital, there's an amputation done. Where they will go after that is very dependent on who their healthcare providers are and their knowledge. This study undoubtedly will give the evidence-based medicine, the numbers, to prove that the setting of inpatient rehabilitation is second to none for those after limb loss. In that 300 to 500 people a day, 42% of those are minorities. It becomes more of a vulnerable group. 75% of them are over the age of 60. Again, a vulnerable group. So we're very dependent on our healthcare system, our doctors, our social workers, our case managers, to understand the outcomes of this study, and to take it in very bold terms to them in an education program, in the media, to have them understand that this population should be served in no other setting. Because what are the outcomes? What are the policy implications? Well, the policy implications mean that there may be $12 a day more spent, but the outcomes are about who gets to live longer, who gets to stay at home longer, who functionally gets back to work and gets back to life. It's about using a team of healthcare providers in the inpatient rehabilitation setting, doctoral trained physical therapists, master's prepared occupational and speech therapists, physiatrists, medical specialists. The lights are on 24/7, and these people are there every day trying to produce outcomes in a shorter amount of time that are produced in any other setting. It's dramatic. And to have our policymakers understand this and to be able to move on it after today's briefing, hopefully will change the outcomes for so many more, possibly 300 to 500 a day in America. So with that, when we look at the long-term consequences, we want to understand that there's a face, like the gentleman I admitted yesterday is a 64-year-old. He had no idea he was going to lose his limb, and that's what he experienced every day. But he lives alone, and I told him, probably the first week in August, we're going to have you up on a prosthetic. If I had not seen him in this setting, but he went through a different setting or home, most likely I'd see him a year later, and maybe he'd still be able to use a prosthesis, because there's this window where you can become contracted, and you become weak, and you become sick. If we look at this 70 to 8 more days of life, if I told you that you had pancreatic cancer and your life expectancy to be alive in 5 years was 40%, you'd be like, get me the best care and get me to the lead professional in the area. If I told you somebody who has a diabetic foot ulcer, somebody who has an amputation, has that same prognosis, would you be sending them to any place else but to the team of experts and professionals? So I am so indebted to Dobson DaVanzo, to AMRPA, for the lead in this. And hopefully it will be what we hope it will be a change in the world that I work in every day. Thank you.
We're going to now introduce to you Susan Connors, who's the president and CEO of the Brain Injury Association of America.
And I'm the only speaker who doesn't have initials after her name. The Brain Injury Association is the nation's oldest and largest patient advocacy organization, brain injury patient advocacy organization. We serve and represent the 2.5 million people who sustain traumatic brain injuries each year. You guys have heard a lot about TBI recently. And also the more than 1 million people who sustained acquired brain injuries. Acquired brain injuries are strokes, tumors, metabolic disorders, toxic exposure, infections, et cetera. So we're talking about 3.5 million Americans, civilians. This doesn't include service members that we've been hearing about over the last decade. There are a couple of quick points that I want to make, some basic education about brain injury. The first is that any brain injury, whether mild, moderate, or severe, can change the way you move, the way you think, the way you act, and the way you feel. And we've seen some demonstration this morning of the physical consequences of brain injury. It can cause temporary or permanent paralysis. It can interfere with or create balance or coordination problems. Brain injury can cause hearing, vision, or speech loss. Some of the cognitive issues include memory loss, concentration difficulty, attention deficit, and then certainly impulsivity, impaired judgment, anxiety, depression. These are all common behavioral issues after brain injury. So let me try to make this a little bit concrete for you. Imagine not knowing the difference between a hairbrush, a toothbrush, or a paintbrush. Or forgetting which goes on first, your shoes or your socks. Or being unable to control one half of your body. Or not knowing exactly what might come out of your mouth. This is brain injury. The reason that the Brain Injury Association of America is so absolutely thrilled and grateful for this study and thrilled to be part of the release of this study is that rehabilitation is the single most effective treatment for people with brain injury. It's the single most effective way to restore function, and it is the only way to slow, stop, or reverse the disease processes that are caused or accelerated by brain injury. There's no magic pill for people with brain injury. Given that 3.5 million Americans, everyday people, just like you and me, will sustain a brain injury at some point during your lifetime, someone you love, your parent, your spouse, your partner, your sibling, your boss, maybe you don't love your boss, but it happens all the time. Someone you love will sustain a brain injury, and when that happens, you will want them to have rehabilitation. And you'll want them to have rehabilitation that is of adequate scope, duration, intensity, and timing. And you've heard today about how important comprehensive, intensive rehabilitation is to the recovery of the senators who've been here previously. This study demonstrates what patients with brain injury and family members and advocates have known all along, and that is that care in a skilled nursing facility is not the same as rehabilitation in an inpatient rehabilitation hospital or unit. It just isn't. It's not the same. And the truth is we don't want it to be the same, right? We talked about the different settings of care. I have an old-fashioned audiovisual here, this little poster over here, and it gives you a demonstration of all the different settings of care that someone with a brain injury might utilize during the course of his or her recovery. I am not suggesting that an IRF is better than a SNF. That's not my message at all. What my message is that these are different settings of care. They have different purposes. They have different licenses. They have different staffing patterns. They have different treatment plans. They have different regulatory requirements, and they have different payment systems. And they should, and we need them to have different payment systems because we don't want to pay the same amount for an outpatient clinic as we would pay in a ICU, right? I mean, think about that. The other thing that this study really points out for me, and it's something that I've been struggling with a lot, is this concept of site neutrality. And there is no such thing as site neutrality. It's just, site neutrality isn't. It doesn't exist. And we don't, and as I say, we don't want it to exist. I know that Congress is looking at taking on transforming post-acute Medicare, right? IMPACT Act that's just been introduced. And my message is that to Congress, and so to all of you, is that we have got to ensure that we preserve all of these different treatment settings so that patients get the right treatment in the right setting at the right time. In my view, that's what patient-centered care is all about. We don't want to sacrifice long-term outcomes for a short-term, something that looks like it's less expensive in the short term, but really creates longer-term outcomes. You went through some of the study, I'll reiterate because it's especially striking for people with brain injury, both stroke and TBI. 14 to 16% live longer, 14%, 14 to 16%. Out of the hospitals, out of the facility 16 days sooner. It's the ER visits, I think, are about 4%, is that right? ER visits, and in the case of people with stroke, it's 10% difference. And this is for $22 a day. So let me put that in context. That's for TBI. For stroke, I think it's about $16 a day. Do you know what you can buy for $22 a day? I mean, besides coffee and things like that, In my world, what you can buy is about 2 hours of time from a personal care attendant. That's somebody who will help you with the activities of daily living, dressing, bathing, toileting, feeding, etc. So for my money, I would rather spend $22 for TBI or $16 for stroke. I would rather make that investment up front and have stronger health outcomes, stronger functional outcomes, stronger independent outcomes, than shift those long-term care costs downstream to, by the way, states that are dead broke and families who can't afford it either. So when we think about Impact Act, let's make sense. Let's think about what we're doing. Let's think about what we are consigning to Medicare beneficiaries, because, by the way, it's not just Medicare. America's health insurance plans, is anybody in the room from AMP? But I mean, Blue Cross Blue Shield, United Healthcare, all of them, they all do what Medicare does, right? We know that. So remember that, and besides, Medicare beneficiaries, 15% of beneficiaries are under age 65. So we're not just talking about our grandparents here or older people. We're talking about the entire population. These decisions that Congress is contemplating about post-acute care will impact all of us. And so what I'm asking you guys to think about is, what's the patient-centered care you want for yourself or for someone you love? Thank you.
I'm going to take the chair's prerogative to give you a couple of points on the perspective from the rehabilitation hospital community. And as the purchasers of this research, I can tell you that when we had the results of the study revealed to us at the ARA Research Institute, we were absolutely stunned and shocked by the findings. We had all been arguing for months and years about the rehabilitation activities, the comprehensive team, the focus on things, and here we are with these folks coming along and say, well, you know, these people really die a lot quicker if they haven't been in a rehabilitation hospital. A very substantially significant observation over a 2-year period of time. And we said, well, no, wait, what are you talking about? It's rehab, and suddenly it jarred our perspective about the conversation has been, well, it's the same activity just in a different setting, so therefore it's the same thing. This is clearly proof that it's not free of impact from the setting in which the activity occurs. When you're taken care of by doctors and nurses for a lot longer time, and you're selected into a facility by a physician, and your team is working intensely and in coordination, the evidence speaks for itself. There is clearly a consequence on life expectancy, on quality of life. To have quality of life, you first of all have to be alive, and secondly, you have to have the opportunity to be in the community to experience a higher quality of life. So it put into stark contrast for those of us who work in rehabilitation hospitals and provide these services that it's not just our therapy, which is wonderful, which is intensive, our pain-inducing physical therapists, no pain, no gain. You didn't come here to rest. This is not a relaxation home. This is to get stuff done. What do you mean you don't want to go to therapy today? Get up and get out of here. You're in the gym. I mean, that's the way we behave. We're kind and gentle about it, but we tell people that they're here to work and to accomplish things, and we're here to help them. It makes an incredible difference. And this evidence that has been provided by the study has really reinforced our intention to make sure that you all understand that evidence should guide public policy just as it should guide the practice of medicine. And we're delighted to offer this compelling evidence to help support finding the right ways to reduce Medicare expenditure. We want to preserve the trust fund just as much as everybody else in this room. I've got my Medicare card in my wallet. It means something to me personally. I really want the trust fund to be available, so God forbid I ever need my own services, I'll be able to have access to them in the right location. And so we are encouraged that this is not the end of the analysis. This is the start. We will be ecstatic if other interest parties would like to engage in honest brokered research to study the issues in more detail for themselves and to prove what is the right thing to do, what are the right policies. We think it's pretty clear that site neutral is not ready for execution, that it's not site neutral outcomes, it's not site neutral care, it's only site neutral that you could possibly achieve a site neutral payment, and that's just not enough for what people need. I would like to invite all of our speakers to come up to the panel table here and open the floor. If there are any questions or comments, we'd be more than happy to receive them at this time. There must be somebody who disagrees. Yes? Okay. Okay. Right. Yes. Right. Right. Sure, and I'll open up, maybe I'd let Al speak to what the data show first.
What is your question precisely?
So this study seems to disagree with NPAC's survey in their June 2014 report regarding outcomes and payments, and whether they are advocating for site neutral payments for certain select orthopedic.
Well, and if you look at some of the orthopedics in our study, the differences there are less pronounced. I don't want to get into this and that, but, and they did cite our study, industry-funded study is, I think, the phrase they use. And I think that there was an earlier RTI study that suggested that our results are in line, where they found after you adjust for this, that, and the other, and you compare patients, the mortality and the outcomes are better in the IRF setting. The site neutral thing is particularly difficult because there is a cost difference. So then what you're coming down to is what's value, what does society want to pay for? And I think what we've heard from speaker after speaker this morning is when you look at the totality of it, you really got to be careful with this site neutral thing because you may be throwing the baby out with the bath. And I think that's the kind of public policy that should really be carefully considered. And we've done some work with some other folks on the site neutral. The costs are different. There is a policy out that would have site neutral payment where you take the SNF payments, you take the IRF payments, and you take some of the spread and you blend it a little bit. Perhaps you could adjust for case mix. Something like that that kind of throws the dollars back a little bit to the institutional settings where actually more care is being provided makes a lot more sense than pure site neutral. Pure site neutral assumes that the outcomes are the same. We disagree. And I don't think MedPAC disagrees either. If you read carefully what they say for certain conditions there is a difference. So it says that if you were to do site neutral, you'd want to be extraordinarily careful. You may want to adjust it as some of the other provisions have where you take some of the spread and you throw money back at the IRF because it does cost more to provide more care. One thing I don't think we want to do, and this is just me talking now, you don't want to take the IRFs and make them look like the SNFs by changing the regulation.
Thank you. That's right.
Because then what you end up with is SNFs.
That's right.
That's
More
not what we
SNFs.
want. We want IRFs. We want to preserve the difference. And I think that a pure site neutral that doesn't preserve the difference is not a good thing. That's just me talking. And I think our study supports that any kind of thing that says we're going to neutralize the difference and take away the capability and then pay for that neutered system, that doesn't make any sense. You want to keep the spread, you want to keep the difference, you want to keep the positive outcomes, and you want a payment system that sensibly supports that difference. And I think the sensibly is the hard part. But purely to then take a policy, take away the regulations that make IRFs and make them look like SNFs and then pay site neutral, what you've done is you've changed the delivery system. Probably you don't want to do that.
I'll give you a perspective from purely from a clinical perspective, not data and evidence. No two patients are identical, even with a common diagnosis, and we can talk about joint replacement patients in particular. The typical joint replacement patient that gets admitted to a rehabilitation hospital has they get admitted with about 12 to 14 different drugs they're taking every day. They have hypertension, diabetes, they're obese, they have a variety of chronic disease conditions. They haven't been walking much because of the problem with their knee pain, and they are debilitated. And they are basically very fragile and risky patients. The 55-year-old tennis pro who's racked up his knee because of all the aggressive use, who's bench pressing 275 pounds outside, is not the kind of person that needs to be in a rehabilitation hospital. And the problem with site neutrality and the problem with aggregating and generalizing by a simple label of joint replacement is that it loses the clinical nuances of the fact that we're talking about individual people. I take care of people one person at a time. I don't take care of a population, I take care of individuals. Now, we care about population health, but you don't want to sacrifice the health of an individual for the sake of the population, and you can't rely on a broad, blunt public policy to really shape the decisions that physicians and nurses and doctors need to make every single day about whether I belong in this particular care setting. It has to be allowed. The system has to support good clinical judgment as well as rational public policy. Peter.
Dr. Sheen and Dr. Gans, you hear so much in this debate around site neutrality about how the settings are pretty much the same and that the service is provided the same, the patients are getting the same type of service. But in fact, the regulatory requirements for EMS and IRFs are completely different. And I'm hoping, Dr. Sheen, you see this every day, you're talking about your own experience. And Dr. Gans, could you please just elaborate some of the different requirements of these two different settings?
So, and again, this is the everyday world I have. So as a chief medical officer, I have administrative responsibilities. And who am I answering to? Not only to the hospital itself, but to the standards that we have through our Joint Commission and our Commission on Accreditation of Rehab Facilities. And I'm from the state of Maryland, so if I don't have those, our doors are closed, and we're not able to do that work. And now as I go into very specifics, so as accredited by the Commission of Rehab Facilities, CARF, we have specialty programs. So we have amputee, brain injury, stroke, and spinal cord injury. And each one of those has 1,000 to 2,000 different standards that we have to meet and upheld. That is not the process in a skilled nursing. There is no Commission on Accreditation of Rehab Facility that's demanded of our skilled nursing facilities. That the regulations within the skilled nursing is governed by a Joint Commission, but the regulations are much looser. The expectations that a healthcare team be fully engaged with a person in a skilled nursing facility is not the same and not guided the same in an acute rehab. In acute rehab, patient needs to be seen pretty much every day by a physician, nursing care 24/7. In a skilled nursing facility, the doctor visit can be just once a month. Okay, the rehab provided 3 hours a day, 5 days a week, as well as weekend therapy. In a skilled nursing facility, it is about 2 hours a day. The team specialized in brain injury, amputee, spinal cord injury, does not exist in a skilled nursing facility. They are physical therapists, physical therapy aides, occupational therapists. If there is a speech therapist available, that's wonderful. So the overarching regulations and standards are so much more rigid for an acute rehab environment, and that's what Bruce, Dr. Gans, speaks to, that we are pushing. We know we're under the gun to produce certain outcomes and have somebody moved out of this site, or we're going to be further reprimanded for the dollars that are spent in trying to do the work that we do.
I'll just put a little another nuance on it. You see one rehab hospital, you've kind of seen all rehab hospitals in terms of the overarching structure, the patterns of care, the kinds of professionals you're going to find, because hospital licensure, regulatory expectations. Medicare has a very rich and abundant set of standards that really define a lot of the medical, nursing, and therapy activities that go on. And the contrast is that when you see one nursing home, you've seen one nursing home, and you have to look at each one very carefully, because there's no way to predict that there's this universal standard of what must be going on because of any regulatory or structural expectation. Personal story. My 95-year-old mother-in-law was living in assisted living, became acutely ill. I had to get her admitted to an acute care hospital in upstate New York. She became severely debilitated and required rehabilitation. I pushed them to move her into the rehabilitation hospital because I knew that facility well. I knew my mother-in-law well. I knew the kind of drive and pressure she needed. I knew what she was capable of responding because I knew what she'd been like just a week and a half earlier. The new caregivers thought she was always this weak, frail individual, and I knew this was just a response to the acute illness. She started to do wonderfully well. She became acutely ill again, despite their best efforts, went back into the hospital, more illness. At that point, she needed rehab, and I said, she is not going to do well in the hospital level rehabilitation. I need to bring her into a rehabilitation skilled nursing facility. And then I shopped, and I visited about a dozen different facilities, and I evaluated with my peers and the individuals, say, who has the kind of outcomes, the quality, and I picked the best of the bunch, which was far from geographically convenient, but it was the right location for the right program. And she did very well. She became acutely ill again, had to go home, had to go back into the nursing facility one more time. Finally, we brought her home to live near us, and she lived another year and a half, quite functional in an assisted living facility. So it's not that one is bad and one is good. It's not that one is right and one is wrong. It's the right setting. And unfortunately, you have to do a lot more shopping in the environment of the skilled nursing facility because there's so much less capacity to predict based on regulatory standards as to what you're going to find inside.
I'd like to follow up on that just a little bit. Our study does not say IRF's good, SNF's bad. Just doesn't say that. It says in some instances, for certain patients, IRFs are the place to be. You're going to get better outcomes. There are some patients that maybe don't even need a SNF or NERF. They can go to home health. Some can just go home. Some of the orthopedic places. It has to do with the patient. It has to do with the prognosis. It has to do with the circumstance of the patient. Right place, right time, right place, as we've said. Sometimes that's a SNF. Sometimes it's home health. Sometimes it's actually home and outpatient therapy. And we have to be very careful that we don't try to jam everybody into a box and say, everybody goes here, everybody goes there. It just doesn't make any sense because that's not the way the system works. It wasn't designed that way. And a regulatory authority actually now is not too bad in terms of actually creating a group of institutions that provide high-intensity care for many people. As our study says, that's exactly the right place to be.
And sometimes it's the right time for the right person. So I have had patients go back and forth where they'll go into a skilled nursing, they'll come to us, but it's about using the right part of the continuum at the right time and achieving the right outcome. But it is an evidence-based medical decision, not one based on finances or education level or socioeconomic background.
It's not linear. Even though it's presented in that poster as being linear, it's not linear. Patients enter and exit and re-enter the continuum of care depending on their needs. It's that patient-centered thing.
Do we have any other questions? All right, well,
Hey,
I'm
I got one.
sorry, yes.
One question I had is, the combination coverage all Medicaid, Medicare, and private insurance, or is just Medicaid, Medicare by itself, or is it a combination of all of three reference to it?
So,
Who covers it? I mean, it's,
Currently, right now, just a combination.
so it's all payers. So,
yeah, they
and-
all pay it, but they're all trying, but, you know, I mean, everybody's trying to pay less,
And
you know? So if in our experience at the Brain Injury Association, we have a lot of patients who are set to be discharged to a skilled nursing facility, and they're fortunate to have a family member or a friend, an advocate, who will call our organization and say, here's my loved one's situation. Is a skilled nursing facility the right place for them? And a lot of times, sometimes it is. I mean, if you have serious medical complications and you're not ready for intensive rehabilitation, then a skilled nursing facility may be exactly right for you. But, you know, hello, Mr. Waxman. But it's not always the right place. You know, an IRF could be the right place. Or frankly, as we said, you know, you might skip over, you might have had such a strong recovery in the acute phase that you might skip over and go to home health or go to an outpatient clinic or go to a residential rehab, transitional rehabilitation facility, something that's more community-based, less institutional feel. So, but it's really about letting the doctors, letting a multidisciplinary team identify, diagnose what your needs are, and then giving the doctors the freedom to prescribe the proper discharge plan for you. That's what it's really about. It's not having the payer control what happens to you.
So when it is all of the payers, and if I can,
Right. It's
I
not
don't
just
want to
Medicare.
rant, but it is about every day, follow the leader. So
Yep.
Medicare is the leader. And with that, the commercials will follow it, but the commercials then divide themselves into different product. Some may be a Medicaid product, and you may have a commercial insurer that has a Medicaid product that says yes on one case
Right.
and no on the other
Right.
based on that product. And it's a maze we go through, but the individual pieces is what we need to assess every day. I need to go through a list of diagnoses and then the key diagnoses to say they should be served in here, and not about the money. But the assumption is that in the acute hospital, the physician is aware of the post-acute setting. And that's not true. So what they do is they delegate that to a case manager or a social worker or a physical therapist, and from there, the decision of the post-acute setting is made. So that's where I brought up, it's about trying to use this evidence-based medicine to hit it home to the leaders of the team in the hospital, to have them know where their patients are going and what to do with it.
I see Congressman Waxman's in the room. Welcome.
Thank you. I just wanted to drop in to pay my respect.
You can have my mic.
Come here.
It's so important, I'm looking forward to studying the report that's been done, because we need to recognize this, as you say, continuum of care, where people have the need for acute care services, that's necessary, but afterwards,
Right.
rehabilitation hospitals serve a very important role. And as I understand the report, it will show that rehabilitation hospitals are a very effective place for a lot of people to go, rather than institutional care of some sort that will not give them the services they need.
Right.
So I'm looking forward to the report, and thank you all for the work you're doing. I think you all represent the patient's interest. People throughout the system represent the patient's interest, but they don't always know what's in the patient's interest, especially after they're discharged from the care.
Thank you. Thank you so much.
Thank you.
A very long-standing advocate for rehabilitation hospitals. I appreciate his comments. There's a question in the back.
My name is Toby Evelyn. I'm with the Center for Medicare Advocacy. We're a public interest law firm that represents Medicare beneficiaries and a member of the Coalition to Preserve Rehabilitation. Very concerned about the loss of IRFs, and certainly we're part of the coalition when it's fighting the 75% rule. My question is to Dr. Dobson. You have such stark findings about traditional Medicare. You said that you haven't looked at managed care, where an increasing number of Medicare beneficiaries are getting their care. Is there any interest or ability or plan to look at what happens to people in managed care when they have the full continuum of options available for them for post-acute care?
Very interested, and Dr. Gans is very anxious to answer that question.
Cha-ching.
Hard to get the answers. Finding the data source is a real challenge, but clinically we see dramatic differences in the ability to get patients in the door if they're managed Medicare beneficiaries. They're being denied, they're using standards that we don't agree with as criteria. So it's a very, very, very dramatic, experientially it's very dramatic difference, and we're looking to find the ways to demonstrate that quantitatively, not just qualitatively and experientially.
I do want to take a shot at that, too. We're going into a world of bundled payment, and the prices are different, and we're really going to have to pay attention to outcomes and quality under bundled payment, and Medicare knows that. Medicare isn't doing anything now where they don't have quality measures, outcome measures, but in this particular instance, if you just look at the numbers, you could make the wrong call every time. So we want to make the right call more often than not, as we said. And the right call is very important for the patient, but it's not numbers driven. If we just let the dollars drive it, we're going to screw up. And bundled payment could do that in excess. So we have to be very careful when we go to these systems that look budget site neutral, that look like the cheaper thing is always better. It isn't always better. And we're going to have to be, I've been a payer, I helped build the DRG system in the 80s. I know these payment systems have enormous power. And we're going to have to be very careful when we go to more powerful payment systems that we don't get less powerful medicine. We really could if we're not careful and we don't have the right kind of outcome measures, the right kind of quality measures, and think our way through it as opposed to blindly go for site neutral and say, oh, the outcomes are the same, when they clearly aren't the same. They're clearly very different. We have to really pay attention to what we're doing as a nation as we build our payment systems.
I would just add that the Brain Injury Association of America has just awarded a major grant to Mount Sinai School of Medicine, a huge grant for a big collaborative project among the leaders in brain injury to develop guidelines for rehabilitation and disease management of moderate to severe traumatic brain injury in adults. This is a major 3-year project where we're trying to use evidence-based medicine, use published literature, as well as professional consensus to determine who goes where, when, and gets what kind of care. Because we understand that bundling is upon us, and we just want to make sure that people with brain injury don't get the short end of the stick. You know, the truth is, Medicare doesn't pay for 8 days of an antibiotic when we know that 10 days is what's needed. We're not trying to short shrift on chemotherapy or kidney dialysis. Why would we try to short shrift on rehabilitation? It doesn't make any sense, and in some ways it's grossly unfair.
So through the Amputee Coalition, now probably about 7 years ago, with the Commission on Accreditation of Rehab Facilities, we developed the first standards for those with limb loss. There had, up to 2008, been no standards of care for someone after they've experienced limb loss. And we set those as the concept of site neutral. If you can meet all of these and produce these outcomes, so be it. Just do it where it needs to be. It just so happens that in acute rehab, this is where the team comes together. This is the most efficient way to bring this level of healthcare professionals together in an efficient way to get the job done. And it's about lifetime care. Nobody's brought that up. Acute rehab isn't about a stay. It's about a start of a relationship and lifetime care. I take care of patients. The gentleman I met yesterday who's an amputee, I will take care of him until either he leaves or I leave. And that's for the rest. It won't be under the setting, but it's about starting the relationship. Same thing with brain injury and spinal cord injury and stroke. We are there to provide and support all the outcomes we're boasting about today for the rest of their life, the best that we can.
I'm going to draw us formally to a close. I want to again express my appreciation to Senators Kirk and Johnson for their participation, support, and their staff for making this possible. Speakers, thank you all very much. It was very compelling. I learned stuff. And hopefully you all have benefited by being here. Thank you all very much for coming. And we'll probably see many of you in the halls of Congress as we continue to try to work together to make things better for the patients we're here to serve. Thank you very much, and we're adjourned.